Finals SAQ24 IV drug administration errors. A. Which human factors contribute to IV drug administration errors in theatre-based anesthetic practice? This includes lack of knowledge, unfamiliarity with a particular drug or route of administration, etc. Human cognition. Human memory cannot be relied upon to remember all infusion mixtures and dose variations. Difficulty with complex calculations such as pediatrics and infusions. Lack of knowledge of certain unfamiliar drugs. Distraction. Needing to address other tasks while also drawing up drugs, prescribing drugs, calculating doses, and giving drugs. High noise levels produces distraction. Stress and fatigue. Tiredness, for example due to night work, and non-work emotional issues, reducing work performance. Lack of teamwork. Lack of double checking of drugs. Failure to feel able to voice out. Lack of knowledge about a particular drug and its administration. Failure to implement a no-blame culture. Lack of encouragement of reporting and learning from errors. Poor communication and poor handover. Failure of one member of a team to give explicit instructions to another about the administration of a particular drug, or whether a drug has already been given. Excess physical demands, excessive workload such as high turnover list, and physical environment, cluttered workspace, low light levels, drugs with similar packaging, changes in packaging without notice, unclear or too small labeling and lettering size, all contribute to IV drug administration errors. B. Outline the organizational strategies that might minimize IV drug administration errors. Processes. Standardization of cross-checking, handover, infusion doses, diluents. Availability of reference databases for doses, calculations, and diluents. Regulations regarding what is drawn up and by whom, and at what stage in the care of a patient. Avoidance of distraction during drug preparation. Checklist to ensure prescription chart is checked before administration of drugs by anesthetists to avoid double dosing or omitted doses. Investigation of possibility of premixed infusions and flushing all lines as standard before leaving the theatre and recovery. Physical environment. Standardization of layout and contents of anesthetic carts. Ensure intrathecal and epidural drugs are kept separate from IV drugs. Removal of non-essential, rarely used drugs from anesthetic cart, which have high risk of injury if inadvertently given. Ensuring label availability at all times. Process for dealing with unused ampules to prevent them from being returned to incorrect box. For example, having a second person check or discard altogether. Ensure adequate lighting levels. Sourcing of products with clear labeling, sufficiently large lettering wherever possible. Next is teamwork. Simulation sessions to highlight risks to all team members. Unusual drugs to be dealt with in the team briefing. Encouragement of working environment where any team member feels able to voice concern. Inclusion of pharmacists in the team. Notification of team members about changes in product appearance. Education about new drugs for inclusion in anesthetic carts. Management of error. Open incident reporting with no blame culture. Lead clinician who will analyze factors contributing to error and be responsible for national reporting. Morbidity and mortality meetings for education of all team members about pitfalls that may lead to error. Communication of safe anesthesia license group reports to all team members to help everyone learn from errors that have occurred nationally.